This is obstructive azoospermia, in which there is a blockage to the outflow of the sperm somewhere between the testicle and where the sperm enters the urethra tube in the penis prior to ejaculation. Now, of course, when there is an obstruction, we would expect to find large quantities of sperm dammed up either in the little epididymis tube or in the testicle itself. And therefore, the proposition of retrieving sperm in such cases is really much easier, and there are far many alternative approaches. The simplest, when the sperm is dammed up in the epididymis, and one can actually, on examination, feel the epididymis, which may be 0.5 centimetre or 1 centimetre wide, then of course the simplest approach is to put a little needle through the skin of the scrotum into the epididymis and to aspirate the sperm. But of course, we can do a small operation and achieve the same thing, actually looking at the epididymis, and the argument for doing perhaps a more extensive exploration is that this gives us the opportunity to look around and find the best sperm, because often in these cases we will be freezing the sperm, and therefore, as I mentioned in the previous section, we would like to get the very best sperm so that when it is thawed after freezing, we get sufficient motile sperm for the embryologist to work with. But in some cases of obstructive azoospermia, particularly when managed by our colleagues, our gynecological colleagues in the fertility unit, then another simple approach is merely to put a larger needle into the testicle itself to aspirate the sperm, because in obstruction there will be a lot of sperm in the testicle. And this procedure is called a testicular sperm aspiration, or a TESA, T-E-S-A, in contradistinction to the micro-TZ that I was describing previously. When one undertakes the needle aspiration of sperm from the epididymis for obstructive azoospermia, that is called a PESA, that is a percutaneous extraction of sperm. And when we look at the epididymis to aspirate the sperm to try to get the best quality sperm, that is called a MESA, or a microsurgical sperm aspiration. And so we have various approaches in obstructive azoospermia, not surprisingly, because we expect to find sperm. But in the non-obstructive azoospermia, where the overall retrieval rates are only 50%, we have different approaches with the preliminary diagnostic step for some patients and a micro-TZ, either directed by the map that we might have made or undertaken electively with the ability to freeze any sperm that we have found. I suppose when one is considering the whole picture and the global approach to this difficult subject of non-obstructive azoospermia, which I think psychologically often causes a lot of upset and unhappiness because the future is so uncertain, that when we can achieve a diagnosis before we get to the point of IVF ICSI treatment, if we can achieve a diagnosis, then this can be very settling to the couple because we have a very clear pathway. One of the most devastating cases that we all deal with are those in which we undertake a big procedure for a man with non-obstructive azoospermia, and we find, despite our best attempts, no sperm. And of course it is a feature of human nature that although we discuss the 50-50 likelihood of success, people will naturally, being hopeful and optimistic, hang on to that 50% success, and they will tend to push the 50% failure rate out of their minds. And this comes as a terrible shock. And so wherever I can, I would like to try to make the diagnosis before we get to that critical day with all that disappointment and heartache.